Hi friends, good evening. I'm Dr. Ashutosh Gupta, and let us talk about some technical issues regarding an IVF pregnancy. Okay, so what we believe is this that the IVF pregnancy they stand in a slightly higher risk as compared to a normal conception for microdeletions, right? Anyways, we identify that there could be 1 to 2% risk for any sort of a chromosomal aberration in every pregnancy, as a matter of fact. Okay, and with IVF, the risks slightly increases. Right now, what we are dealing up with the case today is a DADC twin. Okay, meaning thereby that in the uterus we are having two pregnancies which are fraternal, genetically they are different, right? Meaning thereby that there could be some genetic etiology, right? Now, what we are dealing with is a sort of a growth discordance. So any discordance of the growth between A and the B fetus greater than 20% of the larger weight becomes a discordant twin. Mostly, we believe that it is because of the unequal placental share. So the bigger one has got a bigger placenta, and then the smaller one has got a small placenta, and therefore it behaves in that way. And therefore, there could be some issues regarding the umbilical artery that the bigger gets the bigger chunk of the nutrition available from the mother, and then the smaller gets the smaller chunk, right? But in our case, so this is an IVF, this is a DADC twin. We are seeing for the first time at 26 weeks. She has come for a follow up, and then we identified that one of the fetus is not growing appropriately, right? Okay, and then what is the normal, usual ultrasonographic parameters that probably we wish to identify so as to explain this discordant twin growth were absent, right? So what more that probably we can do in a non-invasive way, then probably we'll discuss all these things. So this is the biometry that we are doing at 26 weeks. So this is the A fetus which is growing normally, and then this is the B fetus. We identify that all the parameters are lagging by 2 weeks. Then we put all those things onto a graph and we identify that the B is really lagging behind in the growth, right? And then as I've told you, any discordance greater than 20% becomes abnormal, right? So it is 27%. So now what we're trying to look around is this that the middle cerebral artery of and then the umbilical artery flows in the twin A, which is normal, and vis-a-vis we try to look around for the twin B, which is also, so this is the MCA middle cerebral artery, and the umbilical artery is for the twin B, which is also within the normal range. Right now, what we on an ultrasound, non-invasive way, we're trying to look around for something more. So what caught our eyes was, now you see it here. So this is a four-chamber heart, and then we identify that there is some discordance between these. So there is a diminutive LV, left ventricle is diminutive, and the RV is dilated, right? So probably we try to look around for it, and then we identify that there is an element of an aortic atresia, right? So aorta could be hardly seen, and it is sort of an atretic, right? And so what we are dealing with this in aortic atresia. So this is the normal co-twin which is normal, and then we can identify it is only for a reference that the outer looks that great. Okay, so this is what we can identify. We can have these many chromosomal microdeletions in the background. So IVF pregnancy, DADC, genetically they are different. So probably we think that probably it could be an unequal placental share, and we try to look around for the uteroplacental insufficiencies or the umbilical arteries. This is the normal circumstances in which you don't have adequate flow to the baby, which is not growing very well. But in this case, what we believe is that all these things were absent. So probably we try to look around for something more, and then what we caught is this that there could be some element of a cardiac abnormality, right? So meaning thereby that sort of a lesion, what we've identified is could be so this is what we see at the moment is an aortic atresia. So that is leading into a discordance between the left ventricle and the right ventricle, and therefore we are having a diminutive LV. So how it is going to behave, and then probably it can get into an HLHS, which is called as a hypoplastic left heart. So that is for something else that probably we'll see it in a follow-up ultrasound. But at the moment, what we are identifying is this: that the first one is is the difference of the growth between these two fetuses is something around 2 weeks. First, secondly, we are identifying some parameter on an ultrasound that might suggest that probably we are dealing up with some sort of an chromosomal aberration, meaning thereby that probably not today, tomorrow, postnatal, antenatal, whenever. So meaning thereby that at 26 weeks doing the amniocentesis and talking to those microdeletions becomes slightly tricky. Anyways, we really cannot do anything about it. But probably after the baby is born, then also the meaning thereby the genetic etiology always remains. Meaning thereby that after the baby is born, then also probably we would ask, or probably we would warrant, or would advise to do those sort of a chromosomal aberration study onto the fetus that prognosticates the baby, that prognosticates the fetus as far as long-term prognosis, outcome, if the baby would need some cardiac surgeries. So, meaning thereby that there are a lot of things to talk about. There are a lot of revolving pieces that probably we need to put it across, and all those stuff. Had it been a case, it would have been seen at 19 weeks. 19 weeks, we probably could have offered doing an amniocentesis and then confirming the chromosomal makeup, or the of both the fetuses, both A and B, right? So a single finding in the cardiac might lead to a lot of might explain this sort of a growth. So meaning thereby that probably we need to see the growth restriction through the eyes of that cardiac lesion that we're identifying. So probably there now it becomes slightly tentative that probably we can have some chromosomal aberration in the background, right? So this is how the management and the triaging of the fetus non-invasive. Non-invasive, they are still to make up their mind whether they would want to pursue for an invasive stuff and for the chromosomal analysis of the fetus. But this is what we can do on a non-invasive, on an ultrasound parameter. Right? Thank you very much for your patience.